Hello, I'm going to give you one talk and also some links to a second talk. The first talk is very much about the nuts and bolts and mechanics of paediatric spinal cord injury. It's very much a whistle-stop tour. The other one, which I'll give you links to, will be far more associated with the rehabilitation needs as a child goes through childhood and into adulthood. These are the objectives that I'd like. It's due to what the population is, the mortality and morbidity, the rehabilitation and developmental goals, what we do about INSCE in children, and also some overall outcomes to look to see what it is we're influencing when we work with children. Getting to know what the population is actually difficult. There aren't good figures anywhere in the world. Probably the better one is the US National Model System, and they feel that only 1% of children of people with spinal cord injury are children under 16. We think within the UK, out of the spinal population, probably 5%. Difficulties arise whether we're comparing traumatic and non-traumatic together. With children, it doesn't appear to make a difference whether you're male or female to start with, but as different activities occur, risk-taking increases as children grow older, it does become much more like the adult pattern after about age 13. One of the big differences that we also see in children is very much related to body shape, with the head being much bigger than the neck, is that in children under 8 years are much more prone to having cervical injuries, while those in age 5 to 10 much more prone to paraplegia, and complete injuries do seem to be more prominent. In most of the developed world, road traffic accidents in their whole varieties seem to be the primary cause of injury in children. Although children are not likely to be the driver, we would hope, we do see that children who are passengers, and particularly young children who are maybe in a car restrained seat, it's not fitted correctly. And that's obviously one of the big areas for prevention that can occur. Other times it's children as pedestrians and children as cyclists. Unfortunately, a spinal cord injury does reflect the sort of social and economic mores of its own, which country it comes from. Violence is another leading cause which has been increasing throughout the years. We also are seeing increasing numbers of medical and surgical causes, and often this is because the initial treatment the child is being treated for, there has been improvement there, and children who may not have survived the leukemia, etc., are surviving, but however the paralysis remains. Sports do seem to be decreasing, I would think partly because the type of sports which previously caused spinal cord injury are better regulated, and also is the concern that children are actually less active than they were a generation ago. In the first year in particular, we are seeing a lot of medical complications, urinary tract infection being the highest one, very similar to adults, but also a significant amount of pressure ulcers, which is not often thought about in children, autonomic dysreflexia, which may be difficult to pick up because the child not being able to verbalise what's happening to them, and also pneumonia and renal stones also occur in particularly the first year. These are very much related to the very early things. Pulmonary embolus and DVD do occur, and we would tend to advocate anticoagulation in the early stages for those that are post-pubertal. One of the things that we do see is that the increased risk of dying after spinal cord injury is much higher in males, and it does seem to increase in ratio as you age throughout the years. Similar to adults, there is an increased risk depending on the higher level of severity of your injury. It doesn't really seem to follow any particular pattern apart from the A group compared to adults. So spinal cord injury is rare in children. We have no gender difference until approximately age 13 years, and we think that's very much related to risk-taking behaviour. Road traffic collisions, leading cause, and the level and severity associated with age. A little bit more about morbidity. Most common things that we have to be concerned about from the medical perspective are urinary tract infections, pressure ulcers, and autonomic dysreflexia. And unfortunately, there is a high amount of rehospitalisation of children, not during the first year, but also as life goes on into adulthood. But there's no difference in the trends between children and adults in this. The risk of dying, although it is similar in children and adults, actually there are some changes that we are seeing. And although this used to be said, I think we're now seeing that probably in under 15-year-olds, rather than the 16 to 21-year-olds, which are the young person, there probably is an increased risk in early death due to the fact that the trauma that's inflicted on the young body is much more likely to affect other organs, not just the cord. Unfortunately, life expectancy still is below normal for someone who is injured as a child, and there hasn't been significant progress for those who need to survive that first year in approximately 30 years. And the main cause of death overall is from respiratory complications. So what are the factors that really sort of affect living with spinal cord injury? And the two main things that we need to be concerned about is the growth and development and the musculoskeletal conditions. We're still seeing far too much neuromuscular scoliosis and also pelvic obliquity and hip instability. So I'm going to spend a little bit of time going through this. One of the things is that we constantly spend time trying to prevent, and we really have to accept that we can't prevent it, but we have to modify it. These are some worldwide figures of how often we get scoliosis post-spinal cord injury in these children. And as you can see, it's almost but not quite inevitable. It's very much related to the association between the age of the injury and the scoliosis. If your spine is mature when you sustain a spinal cord injury, then you're pretty much escaped. Prior to maturity, 98% of young people will have scoliosis, with two-thirds of those going on to have surgery. So age is probably the only strong predictor. There's been lots of other things looking to see what could be influencing it. Is it related to the hip problems, etc.? But the really good thing that stands out is age. So the younger the child, the more you've got to be involved in trying to reduce the effects of this. And it falls into what we call anticipatory rehabilitation. What do we know is going to be a problem, and what do we do to try and prevent it or reduce the impact? So what's the big fuss? Well, the compensation function is lost. Your child has learned to do something and you're not going to keep that. There's also the increasing worry about respiratory problems and skin breakdown. This can lead to complete loss of function, increased hospitalisation, and a reduction in social activity. There's also the concerns that even the surgery itself is very difficult, complicated. It's not without its surgical risks, infections being high. There's even been reports of vision loss secondary to the surgery. So what do we actually do about it? And one of the things is it really does, it's one of the underpinning components of childhood spinal cord rehab. It's constantly thinking about education and prevention. Even if we don't stop it, we slow it down, get the child older so that they can actually participate in far more activities. And if they do have to have surgery, it is much easier for the surgeons to operate on a larger child than it is on a very small child. So a lot of it is about bracing. It's very much about bracing the correct part. The brace has to be put in place prior to the onset of the curve, and we would tend to brace from the onset of injury. It will slow the progression, not likely to prevent it. Wearing it is incredibly difficult, very frustrating in hot weather. It's hot and it's sweaty. We do know that a brace has been worn. If it comes back for review and it's dirty and fallen to bits, a perfect brace isn't being worn. One of the problems is that some people find that the brace is very restrictive, but other people find that because it does actually help the truncal control, it does allow the child to actually reach out and use what power they have. And you've also got to think about the effects on the activities of daily living by putting that brace on the child. So looking at what the best evidence is, we know that when you do operate and fuse, you will improve respiratory function by reducing the squeezing of the lungs. You will improve posture and sitting balance, but you've also altered it. So you need to consider that wheelchairs and posture and seating need to be checked. Initially, there's a greater risk for pressure ulcers, but this decreases if you actually get the balance correct. And you've got to consider what you're going to change about how the child will feed themselves, particularly in those with tetraplegia, and how to perform such things as the bowel program if the spine is no longer as flexible. But you are actually sort of maybe losing this in order to keep the heart and lung working better. The other big chestnut that we need to look at is what happens to the hips. Because a young child may not be standing, there will not be the growth and development of the hip joint, and therefore we are likely to see 70% of children's spinal cord injury with subluxed hip and 30% of them dislocated. And that again doesn't seem to change no matter what healthcare system you look at where the child has come from. What precipitates the fact that this hip is moving is early age injury, much more likely because the hip joint hasn't formed. There's also the pool of spasticity compared to plasticity, and sepsis and scoliosis all precipitate to hip instability. It is much more likely that with upper motor neuron lesion, you will have hip stability, but it can also occur due to flaccid injuries. And this is one of the things that we would tend to be following up with child for. We've also got to be incredibly aware that if you are irradiating to look at the spine on x-rays on both the long spine and also on the hips, you've got to think of that lifelong accumulation of radiation in children. And that is not an insignificant problem. The problems with this is you'll have increasing pressure ulcers, worsening spasticity and spasms on movement, and the risk of autonomic dysreflexia just because of the hips. So again, what do we do? It's part of this anticipatory guidance, trying to get in there early before things get wrong. One of the most important things is standing, actually reminding that neck and head of the femur of what it's meant to do and fit into acetabulum. Stretching, particularly using prone, trying to keep the bottom down, sleeping prone, early release of soft tissue contractures if they do occur, but preventing them occurring in the first place, sometimes judicious use of Botox. And the bone stability is allowing that child to stand, bracing the child, using them any way to actually get upright, and muscle balancing. We're trying to reduce tightness and reduce high tone to allow growth and development as straight as we possibly can. So one of the things that we're always working with the children is the fact that we have the effects of the spinal cord injury on growth and development, and we've also got the effects of growth and development on the spinal injury. And that is the sort of the constant pull and push of looking after these children. The age injury is one of the strongest predictors of what potentially could go wrong, particularly neuromuscular scoliosis, and therefore we're looking at what does the spine do. The spine also is helping the lungs to develop, giving them space, the abdomen to develop. So it's not just about the bones, it's what they do, what their purpose is. We are meant to stand, and therefore we have to try and get the body from a child, getting them standing using the correct methods so that we can improve their overall health and plan for this child that's going to be well as they move into adulthood. The next thing I'm going to move on to is one of the more difficult things in paediatric spinal cord. It's difficult in adults and it's probably 10 times worse in children, and that's the use of international standards for neurological classification of spinal cord injury, what was Asia and what's now called INSCE, or the standards. There's been so many different variations on this, I personally have given up trying to work out what is the latest, but they can all be downloaded from the American Spinal Injury Association website. Essentially, it's about trying to find out what common language we can have together when we're looking at what has actually happened to the neurological system of the person in front of us. It's not the whole thing, but it's a way of actually having a shorthand method of talking to each other so that if there's any changes or improvements, we can identify and do something about it. So you should all be familiar with the charts, whether it's on paper or whether it's computerised. And to go with it, there's also the how-to manual. It is routinely used in children because we haven't got anything else. But one of the problems that we actually get is that children are given or assigned a neurological level and classification. And it's a label, but it's not often perfect. There's very little reliability or validity, particularly things like the anal rectal examinations. This can be very difficult because the child and the family are then given this label, given this badge, and it does alter, and that can create lots of problems with diagnosis and concern. Is the child deteriorating or improving because of some particular treatment? And so we haven't got an answer to exactly, but what we're trying to do is to get better and better at using what we've got. So what we're meant to be doing is having a reliable method. And as I said, it's not everything. We're looking at motor, sensory, and occasionally anorectal examinations. There has been work done by Mokai in the group to try and get some paediatric guidelines on what we can use. So it is still advocated that you consider using the standards as they are. However, it does need to be done as much as you possibly can. You can't work with a child who's screaming and refusing to take part in it. If you are going to be examining a child to look at the neurological condition post-injury, I would always advise that you go on to the Asia site and that you learn how to do it based on the WeStep guidance. I've also put a YouTube link up there, and one of the things that we have done in the past is to try and just break it down for people to go back and forward to understand how to use the WeStep post-training. You do have to pay for it, and it's part of the Asia membership. We say that you should try in those who are over 6 years of age. You will not be able to do it the way that you do in adults. You have to take your time and do it in bits. And even some children 8 years or even older will not want to take part in it. One of the big problems is even if you are able to perform the deep anal pressure and voluntary anal contraction, particularly if children were injured prior to knowing what it was like to have continence, they will not be able to participate. And as I say, even if you are doing it on a regular basis, we always recommend you go back to the Asian Learning site and continue to sort of update yourself on the WeStep program, which is how this is regulated. Several things which we've taken here straight from the site is looking at what the child does have scoliosis. You see that the dermatomes alter. They sort of concertina in and out depending on the shape of the curve. And so you do have to constantly be aware, particularly if the anatomy is not perfect, of where your dermatomes are. And that can often be a reason for things people think the level has changed. And again, on the site here, not just with the scoliosis, but if you start getting hip subluxation, you will also change where you pick up your termitomes. The next aspect is just looking at some of the outcomes. Again, very quick, broad brush strokes. We do seem to feel that traumatic injuries do correlate with a lower functional outcome, irrespective of level. Children over 10 but under 15 do have higher functional gains than the children over 15 but over time. And the youngest children may decrease in their function gains until 10. The way to improve the child is obviously for general sort of overview medically, but also prophylactic management of the spine and the hips, being very cautious about medical interventions, particularly around surgery, and looking very much at what the child has got the capacity to do. It doesn't really matter sometimes how they do it, as long as they do it. And again, going back to the age of injury, the level and severity all affect the outcome. But the child isn't just a mechanical being. Lots of what we're doing with the work with the children and the families is on the psychosocial aspects and how do we get a healthy adult from the child. We do know that the younger people are participating less than their able-bodied peers, and their activities are sedentary and solitary. Not that that just got problems with psychosocial outcomes, but looking at cardiovascular health a long time, that is a real concern. As a young person ages, particularly as they come up to late teens, we do see that participation decreases when in their peers it would be increasing. The level of injury is also related to the diversity and intensity of activities. There is a gender gap, and girls in particular do seem to still keep on activities with a higher enjoyment level, and boys do tend to come back and be more solitary. And again, cardiovascular problems and mental health problems are the red flags around this. One of the things that we do see is that a lot of these children do go on and they have college education, which can be sort of higher than the population group, which is our second group. However, when it comes to employment, they are far less likely to find employment in adulthood, are less likely to be married, and less likely to live independently. So the longer term goals that people would expect without injury don't tend to be achieved. We focus an awful lot on the spine and the hips, but we have to remember there's also a lot of other issues relating to the skeleton that we see, particularly around shoulder pain. When we're thinking of anticipated guidance, what we do as a child and a child pushing a chair for a long time will have complications in adulthood. Fractures do seem to be rather low in sort of general population studies of this group, and I think that's something that needs to be looked at. It seems too low. Only 5% of these kids have fractures. One of the big things that we've been looking at recently is how do we try and improve measurements. We've got MRIs, but we can't tend to use them all the time. It would be better to have some sort of things like diffusion tensor imaging, trying to look at much more functional aspects. When you can't use an ASIA or INSCI to work out exactly what works and what doesn't, can we use biomarkers and can we use better imaging to find out exactly what's working or not in the cord? And the other better measurements has got to be on actually see what effect spinal cord injury has on the child both now and the future, and also better sort of independence measures. Work being done through Jefferson and the Shriners is on computer adaptive testing, because most of the outcome measures we have at the moment have very much a ceiling and floor effect, and even after weeks and weeks of rehab, you haven't really changed anything, yet the child is actually looking better and doing much more. So we've got a lot of work to be done there.